Good evening, everyone. My name is Adrienne, and I'm a product specialist here at OCULUS. Welcome to tonight's clinical webcast, The Beginning of a Beautiful Scleral Lens Relationship with the Pentacam AXL Wave, presented by Dr. Ken Mahler. You have a text box on your GoToWebinar screen where you can enter questions. Feel free to enter your questions during or immediately after the presentation, and we'll have some time to discuss them at the end of tonight's webcast. If you've missed anything, a recording version of this presentation will be emailed later this week. Our speaker tonight is Dr. Ken Mahler. Dr. Mahler earned his doctorate from the Illinois College of Optometry and is currently practicing in Fort Lauderdale, Florida. His practice is devoted to orthokeratology and providing visual rehabilitation for irregular corneas. He is one of the foremost specialty contact lens designers in the world and authored the First Wave Contact Lens Designer Certification Program. During his 30 years in private practice, Dr. Mahler has lectured extensively and was one of the first doctors to start using the Pentacam Corneal Scleral profile scan during its beta stages of development. He is a member and fellow of the American Optometric Association, a member of the Contact Lens and Cornea Section, and Contact Lens Society. He is also a fellow of the American Academy of Optometry and the Scleral Lens Society. And now, please welcome Dr. Ken Mahler.
Welcome all, and thank you for coming out this evening to listen to the presentation here on the Pentacam AXL Wave and CSP Pro software. And this is really primarily going to be a webinar to elucidate what the AXL Wave can do, the CSP Pro software can do, and how this can really aid in scleral lens designing to make you more efficient as well as proficient at getting to a much better result in the end of your design process. So let's just move on here. To get out of the way here, I do consult for both Oculus and Wave. I am a private solo practitioner in Fort Lauderdale. It is a contact lens only practice, although occasionally I'll see someone that comes in just for refractive status to get a pair of glasses made. It really is a practice devoted to irregular corneas, orthokeratology, and myopia management. I do formal lectures for Wave users and webinars just like tonight. I also do private practitioner consultation services, and that's really where I am helping out the doctors out there on a case-by-case basis, one-on-one training, phone consultation, and remote fitting through telemedicine. I have done beta testing and continue to do beta testing on the CSP and Wave software as well as the AXL Wave hardware. And I'm currently guiding the Wave education and software development so that doctors utilizing Wave can be better at utilizing the software to get to a more successful result. So let's dive in here. What is the Pentacam? For those of you who don't know, it's a rotating shine fluid camera system that takes cross-sectional information through the eye. It provides corneal topography and tomography information, images the entire anterior segment, and can also do axial length measurements as well as entire eye wavefront aberration data collection. There are currently 4 models. There's the Basic, the AXL, the HR, and the AXL Wave. These 4 models are very different. They each have certain features that they are capable of doing. And one of the most common questions I get asked is, so I want to do this, which model do I need? And so what I did at the end here, I prepared a small graphic chart so that you can see which ones will do which features, so that you can better decide what type of device would best be suited for your practice and your intended goals. Tonight is really primarily about the AXL Wave, which is that last one on the end. So let's talk about the Pentacam CSP Pro software. The CSP Pro software differs from the standard CSP software in a couple of very, very important ways. And this is the CSP display screen, so we can see some of the features that we are able to collect. The first thing we see on the left there are the cross-sectional measurements. On the very, very left, you see the columns with the little blue bars. indicating which cross-section you're actually looking through. So that gives you the meridian that you're on, and currently there's a box around number 1, which corresponds to that red line that's on the top. That's the actual arc of the collected data of the sagittal depths that were measured directly off the surface of the eye in that particular cross-section, in this case, the 311-131 meridian. You have here an 18 millimeter display, and so you can see on this particular capture, we've captured data all the way out to the 18 millimeters. Anyhow, let's go on. So the coverage map gives you the idea of how much coverage you were able to capture in that one or two scans that were done. Up on the top over here, you see the scleral angles and the sagittal depth at the selected chord. In this particular case, the selected chord is 16.9 millimeters, and you can see the angles that are displayed as well as the sagittal depths. Down on the lower right there is the graphical and the corneal and scleral elevation in color form, and you have the scale off on the right there. Now this here is the CSP Pro capture scanning screen, and what you can see there, and I put in parentheses plus, is because in addition to the CSP Pro software, you can see that there are other functions checked off here as aberrometry, retroillumination, axial length measurement, and right now we happen to be looking at the CSP Pro display, which is in the lower portion of the screen. The upper ones can be selected, and you can pick and choose which of these you'd like to gather on any particular patient. That's the full scan, so all 4 are checked. Over here you see a coverage map, and that gives you a summary view, and it gives you just a quick glance at the 15 millimeter cord as to how much coverage you actually were able to obtain. In this case, I was able to obtain 84% coverage at 15 millimeters. These images over here are the Scheimpflug horizontal and vertical image. They happen to default to horizontal and vertical, with the horizontal one being the one on the bottom there and the vertical one being on the top. But on the right side there, you can see that blue bar on the up and down arrow ribbon. You can actually pull that up and down, and you would be able to rotate the actual cross-sectional images to take a look at any of the specific cross-sections that you were interested in viewing. And then very last one here is you see the graphical and corneal scleral elevation screen displayed in the colors and the scale on the right-hand side there. This here is the overview screen that comes along with the CSP Pro software. And again, I put in plus because it's not just about the CSP data. We take a look over here, and the first panel in the upper third is really about aberrometry. And so that's all the information that was gathered on the aberrometer being displayed in that upper panel. In the middle panel there on the left, you see the retroillumination, and this is a perfectly normal eye, so there's not very much going on in that particular image there. Down at the bottom, once again, we can see the Scheimpflug images in cross-section, and again, there's that vertical ribbon that you can pull that up or down so you can get any particular cross-section viewed. Here in the second panel, that's the axial length measurement. The one on the left is the graphical view, and you can see just by eyeballing it's about a 26.5 millimeter eye. But in the upper right there, you can see 26.458 millimeters is the actual axial length that was measured. And then in the lower right there is again the graphical corneal and scleral elevation information being displayed there. So let's move on to some of the examples that I've prepared for tonight. This is a 31-year-old black female, diagnosis of Keratoconus, and she had been referred to me 4 years prior. Spectacle RX is 1 year old, and you can see the values there. She's a bit myopic with some cylinder, and the acuity there was about 20/50 minus in each eye. If you're wondering why it was 4 years prior, basically she was scared to come in. And what happened at this point, she had finally reached a level of denial that she couldn't accept any longer. She had to accept the fact she really wasn't seeing very well, and so she had finally summoned up all of her courage to come in so that I can take care of her. I refracted -11, -2, and a -2 1/4, -2. But you can see the acuity was even worse in the phoropter there. So that really wasn't very useful. Health-wise, everything was fine. No medications or allergies. And the rest of the exam was non-contributory. And even though she had keratoconus, she denied being an eye rubber. She did try GPs in the past, and it was an awful experience, and that was pretty much where her fear came from. So if we take a look on the Pentacam screen, data screen here, I've put up both the tangential curvature maps on the upper portion and the corneal thickness maps on the lower portion. These are selectable. You can have a choice of maybe about a dozen different displays, both on top and bottom. But these are certainly very relevant for a keratoconic, and you can see this certainly looks like a very typical keratoconic by the curvature screens on the top. And down on the bottom on the thickness screens, we have the actual data being displayed on the panels, and you can see the right eye there has a thinnest location of 370 microns with a Kmax of 57 diopters, and then on the left eye we have a thinnest point of 361 microns with a Kmax of 59.2. So going back to the CSP Pro display, just to review quickly, we had those cross-sectional maps there. And those are not just pretty pictures. Those are actual maps that are being drawn based on the sagittal data that's been collected. So there's actually a lot of information you can gain just by glancing at those particular arcs there. First thing you can see is that in that inferior portion where the pink arcs are, you can see that we have an increased steepness because look at how the pink arcs are diving down toward the bottom of the screen at a very sharp angle. We can further take a look. Right there on the nasal portion, we have an elevation because you see the deviation that's happening to those sort of golden yellow arcs or sort of golden green arcs that are over there. But you can see that there's a displacement up, and that's actually something that's elevated on the nasal side. Again, we have our 18mm display. Here on the coverage map, you see 3 different colors. Now, those 3 different colors represent the fact that I took 3 captures to gather this data. This particular map was captured early on utilizing the CSP Pro software. And so I did take the 3 maps, sort of hearkening back to my earlier days using the basic CSP software where I needed 5 captures. And so I took the central scan, which is that golden yellow scan, and then I went ahead and lifted the upper lid to get that sort of turquoise bluish scan in the upper arc, and then I pulled down the lower lid to get that pink arc that's down at the bottom. So this was actually gathered in 3 scans. That is not necessarily needed for this, and I did learn as I was moving forward, which we'll see on the next example. Here we can see the scleral angles and sagittal depth that's at that selected chord of 15.8 millimeters. And what we notice here, once again, we have that graphical and corneal scleral elevation. But we also have data that's output to give us an average sagittal height. This would be for those of you who really use fitting sets and are looking for maybe where should I start with a trial lens. This is giving you what the average sagittal height is of that particular eye so that you would know possibly what trial lens to start with and be in the ballpark. So let's move on here to some of the Keratoconic analysis software that comes along with with the Pentacam. And the first thing we have are the pretty graphical pictures that are on the left. We can see both the elevations of front and back along with the float. And then down at the bottom is a very interesting screen where we can see the front and back differences. And what those are a manipulation of the data to highlight whether or not we're dealing with something that would be more like keratoconus or not. There's more information about how this particular screen works, but basically if you have a solid green there, because this is sort of exaggerating the keratoconic, if everything was solid green, you probably don't have keratoconus. But on this particular case, you can see we have both green and the red in the middle, and that's highlighting the fact that this most likely is keratoconus. Next, we have up over here the actual metrics that were captured. And the ones that are kind of important is if you take a look at that lower panel where it says progression index, there's a value in the lower right called artmax. And the artmax is the Ambrosio relational thickness, which is essentially a fraction that's and a relationship that's created from the thinnest pachymetry that's measured on that particular eye related to this pachymetric progression index at its maximum. And so it gives a sort of a statistical numerical value, a number, if you will. Am I dealing with keratoconus or not? Of course, this can be tainted and it still requires clinical judgment, but as a sort of a quick and dirty method so if I wanted a number to say, is this keratoconus or not, that certainly is a very, very good number to look at there. And of course, it's highlighted in red because we're dealing with keratoconus. The next section, of course, is a corneal thickness map, and we saw that on the other screen there, but you can see very quickly that we're dealing with something that's unusual because it's so thin at 370 there, right in the middle. And then down in the lower portion over here, there are two graphs. The upper one is a corneal thickness spatial profile map, and what that is the three gray lines that are going from the 0 out to the 10 millimeter are the average as well as the two standard deviations above and below of the normal population. And the red line is the one from this particular patient. And what you can see there is centrally, she's not even close to the amount of thickness that would be considered normal. It's way above there. And that corresponds roughly with that 370 micron thinnest portion of this particular eye. On the lower portion there, we can see something called the PTI, the percentage thickness increase. And what that does is it's comparing how the thickness or thinness is changing over the profile of the cornea. For example, we don't want just a cornea that tends to be thin mistaken for keratoconus. So this takes a look at how that particular thinness changes over the dimensions, and you can see certainly in relation to the average and the two standard deviation units, that as we move out from the center to the edge, again, she's way off the scale here. And again, this really didn't have much decision making to be taken into account to decide whether or not this really was keratoconus or not. Down at the bottom are a real good numerical summary. The very first number is the deviation of front elevation from normal. The second one is the deviation from the back surface from normal. The DP is the deviation average of pachymetric progression. And again, you can see it's in red, meaning not normal. Those colors are basically, they'll be white if it's considered normal, yellow if it's 1.6 standard deviations from the average, or equal to that, or it'll be red if it's greater than 2.6 standard deviations from the mean. And hence we can see that these are way past what the mean is considered, hence they're in red. The fourth one is the deviation on the minimum thickness from normal. And then the DA is the deviation of artmax from normal. And then what's done at the very end, that last D value, is really the total deviation of those 5 factors all taken into account and summarized into a single number. And once again, if you're looking for just sort of one quick number, do I have keratoconus or not, that's a good number to take a look at, but you still really do need to take a look at the clinical picture, because sometimes corneas are just, they'll have some funny presentations. But that is a very, very good way where if you start seeing yellows or reds, that will draw your attention in to look a little bit further. All right, now here you can see 2 wave lenses that I did for this particular patient. This is not a wave fitting lecture, so I'm not really going to go into a lot of detail here, but that's the modification area. The lens relationship to cornea and sclera are showed in the top half of the screen. The blue arc is the contact lens that I designed, and the gray and white arc out in the periphery is the actual data that's been brought over from the Pentacam to create that actual shape. That's not just a graphic, but that's been created from the unique data profile that's been collected off this particular patient's eyes. There are 4 control points there, so you can manipulate those, put them horizontally or vertical anywhere you like, so you can get the lens design that you're looking for. In the upper left portion of the screen, this is on the left eye there, you can see 4 graphical representations to give you a very quick view of what's going on with the lens. First, in the lower left is the raw corneal data, and you can see that that lower left looks very similar to what we saw in the Pentacam scan, and that's what Wave thinks the cornea looks like, and certainly that's a very good representation of it. And the upper left, that's a fluorescein prediction. Since it knows what the shape of the cornea is and it knows what the shape of the lens you just designed, it can also predict what the fluorescein pattern should look like, and that's what this fluorescein pattern for this particular scleral lens should look like. The upper right is the profile of the lens front surface represented graphically, and then the lower right is the back surface of the lens represented graphically with colors. And on this particular eye, on the lens, you can see in the center there we have sort of an orange color surrounded by a red color, and then in the bottom half there's kind of a white arc, and then there's some blue, and there's a little bit of a green blip on the nasal side of that particular lens, and that's actually representing asymmetry that's contained within this lens. Over here are the haptic data that's being displayed. You can see the edge angle, deviation, and lift angle, and those are giving you metrics on which profile you've created for the haptic of this lens in a particular semi-meridian. So that gives you information about that, so you can have a good sense that you're designing something that makes good sense and should land properly. And then, of course, here is a graphical representation of the tear layer that you've generated between the lens and that corneal surface, whereas the upper darker blue line represents the front surface of the tear lens, and then that low flat line that's going right across the screen represents the corneal and scleral surface. On the right there is the lens symmetry, so you get to take a look at what symmetry you've used, the diameter you've chosen, center and edge thicknesses, the material you've chosen, markings, any optical power that's in there. So it's a good summary screen of what's going on there. So let's take a look at what we did on this this particular case at the very first visit for dispensing. So these are the very first pair of lenses. I did not do any trial lens fitting. I just designed the lens empirically, and you can see on the right eye I hit 2050 and the left eye 2400, and that's primarily because I missed the RX by a considerable amount since it was very difficult to refract her eyes. But with the over-refraction, she did get to 20/25 plus and 20/25 minus with a considerable amount of cylinder in there at against the rule in each eye. At the biomicroscope, the assessment was they were both well centered, about 125 microns of clearance of both. The flange alignment was excellent on the right one, all the way around. On the left one, I was a little bit of edge lift, superior and inferiorly. It had a bit of a toe up appearance. And the rotation, because I did mark the lens since it was an asymmetric lens, was rotated, both of them, about 15 degrees counterclockwise. So my plan was not to dispense the lenses because I was off by quite a bit on the power. So I ordered a new right lens with a power change and a left lens. I did increase the sag at the superior and inferior edge to bring that toe down a little bit. And of course, I put in that power difference as well. So these were the new lenses, and I just summarized that here. On the right one, I added a +1 - 275 axis 80. And on the left one, I added the -6 1/4 - 2 1/4 axis 80. Increased the sag by about 120 microns, both at the superior and inferior edge of that particular lens to deal with that toe-up situation that I saw in that first lens at the slit lamp. Now you can see on the front curvature map that we talked about before, you can see the bow tie actually on both lenses, where it's kind of like a brighter green going top to bottom, and then a darker green going from left to right, and that's actually representing the front cylinder that I put onto this lens. And here we have about 2.5 diopters of cylinder, so that's what's being represented by those colors. So on the second dispensing visit, I did much better on the acuity, 20/40 plus, but I still had a bit of an over refraction. And then the left one I hit dead on at plano. As far as the fit goes, the right one was still fitting very, very nicely. 200 microns of clearance, excellent flange alignment, and the rotation was about the same, a couple of degrees further counterclockwise. But the left one, you can see here, although it was centered well, the clearance was good, and the flange was good, it had a strange rotation of 45 degrees counterclockwise. That was a considerable amount I wasn't expecting, yet the acuity was fine. So I decided to dispense the lenses and hold on any changes. So she came back a couple of weeks later. She said she's wearing them every day. Comfort's excellent. She's seeing great, but at night she's noticing some vertical cones that are coming from light sources, and she is getting better at application and removal. Vision, you can see the right eye was about the same, a little different on the over refraction, but the left eye we dropped in acuity down to 20/40 plus, and this time I was not plano, but I actually came up with some cylinder, and that was probably because of that rotational issue. So when I took a look at the lenses this time, the right one was basically about the same as it was on the dispense, but the left one, you can see, was very different now at 150 microns of clearance. The flange was good, except nasally there was a little compression of a pinguecula, and the rotation was now 90 degrees clockwise. So the concern over the rotation at the dispense visit was certainly well justified, because we could see it really played out once you started wearing the lenses. So I redesigned the lenses and ordered a new pair. The right one, I just changed the power because that's all she really needed. The fit was excellent. And then the left one, I fixed the pinguecular compression by lifting that particular portion of the lens. And then I was a little concerned about rotational stability. So these were my new designs, and you can see on the right one, all I did was just add in the over refraction. On the left one, I increased that nasal flange clearance over the pinguecula, and I figured maybe that might help out what was sort of rotating the lens off axis here, to see if that might solve that problem. So this is my third dispensing visit. Right eye was dead on now at plano, and 20/20 minus. We even got better acuity than I was expecting. And the left eye was 20/25 plus 2, little bit of an over refraction, but you can see she didn't get much better. It was 20/20 minus, so maybe a letter or two better with that over refraction. So I was pretty happy with that. She was well centered on both lenses. Clearance was very good centrally. The flange alignment was excellent. And now we were back to the same rotation we had right at the beginning. So the pinguecula clearly was one of the problems that was rotating my lens off of its correct alignment. I dispensed those lenses. She came back a month later for a follow-up. She's doing great with her comfort. She's seeing great. The vertical cones are gone, and she's doing very well getting the lenses on and off. And now we can see that the right eye has maintained very good vision with virtually nothing over refraction. And the left eye, although there's a little bit of over refraction, it didn't improve the acuity at all. It took her from 20/25 minus to 20/25 minus. So well centered. About 175 microns of clearance in both. The flange was aligned in both. The rotation was right back to where it had been right at the beginning, and now we had no compression of the pinguecula. So very efficiently got to our final pair of lenses, and of course she did very, very well with this. Recheck her in 5 months later, and I've seen her now since then over a year, and she's doing fantastic. So everything has really been very nicely addressed, and she's very stable. So let's go on to example number 2. This was a 71-year-old white female. Diagnosis was corneal scarring, and I put there plus because there's quite a bit more to the history than just some scarring. We can see on the right eye, she had a herpetic and a mycobacterium ulcer within the last year on that right eye. Herpes wasn't enough. She had a retinal detachment along with some macular fluid. The diabetic retinopathy was not helping her retinas at all, so she had some laser treatments there. She also had cataract surgery with an IOL about better than 10 years prior. The left eye is a little more boring, just cataract surgery with the IOL better than 10 years ago. Refraction that I found, and of course the right eye didn't see very well because it really has been through quite a bit. And the left eye really was not doing all that great either, and a lot of that had to do with the ocular surface disease that she was dealing with as well, so only 20/50 plus. So the exam was remarkable for about 4 millimeters of upper litosis on the right eye. I saw a paracentral, inferior, and inferior nasal corneal vascularization on that cornea. The right eye even had a displaced pupil from the various adventures that he'd been on. The pressure in that eye, if the eye hadn't been through enough, is high in the right eye. Left eye is a little high as well, but the right eye was definitely high. And we can see that she had asymmetric cupping with the right eye a little bit larger as well. In the right fundus, I saw the PRP treatments. There were no hemes, and the left fundus was boringly normal. Everything was fine there. These were the maps. You can see the tangential maps up on the top and the elevation maps on the bottom. And certainly the right one has a bit of irregularity to it with those little blips of red and the like there. Once again, we can see here the cross-sectional arcs, and again, an 18mm display. But notice on this one, we have a solid sort of golden greenish yellow coverage map, and that was because it was taken in one single shot. I was able to get out to 18mm because she was able to open up her eyelids wide enough. So it was one single shot that was capturing that. Now, if we take a look at the scleral angles here and the depth, the sagittal depths at the 17.1mm chord, we see something very interesting. We can see there on this right eye that the temporal and inferior have roughly similar angles, but are very, very different than both the superior and nasal side, and they're different from each other. 32-degree angle is quite different than a 40-degree angle, which is very different than about the 48-degree angles that were going on the temporal and inferior portions. The sagittal depths themselves, you can see a fair amount of asymmetry here as well, whereas the inferior, we have about 5,100 microns of sagittal depth, where the other three are all around 4,700. So we really are dealing with a very strange shape for her sclera over here at the 17.1mm chord. And again, there's the graphical information being displayed. The average sag is about 5,100 microns of clearance. And on the picture, you can actually see the displaced pupil on this that iris image that's down in the on the middle and the bottom there. So on the left eye, once again, we can take a look at the arcs, 18mm display. Again, a single capture was able to capture the entire data on all of this. And at the 17.1mm chord, we see something very different now. On this particular eye, we have the about 38 degrees, both nasal and superiorly, where we have about 50 degrees inferiorly and temporally. On the sagittal depths, that kind of mirrors what's going on the angles, whereas we're at about 4,800 there on the nasal and superior portions, where we're at about 52 to 5,300 on the inferior and temporal sides. Again, the graphical information there is being displayed. So, and the average here was about 5,300 microns of sagittal depth. Now, one of the other things also on this graphical corneal and scleral elevation map, we can see here once again that looking at the arcs gives us information. It's not just a pretty picture over there. We notice on the nasal side that there's increased flatness and elevation. On the arcs, you can see how they're kind of lifting up as they move toward the edge of the picture there. And on the graphic, we can see that there's that arc of that very deep magenta color, which corresponds to the plus 150 elevation, 150 microns of elevation on that entire nasal area there. Now, inferiorly, we see more of a steepness and the depression, and that's represented by that purple color at the other end of the color spectrum there. So we can see that's minus 150 microns of depression. And again, if we look at the arcs that are on the left, we could see just how much steeper they look as they're approaching the edge of the graphic inferiorly as compared to what they're doing nasally. So again, you can, just by glancing at those arcs, you really can get a very good sense of what's going on the shape of the sclera here. These are the pair of lenses I designed for her, and it was an 11.7mm cornea, and she also had tremor in her hands. She had no experience handling lenses, So I was trying to keep this lens as small as possible, despite the fact she had a significant amount of ocular surface disease. So since it was a 11/7 cornea, I chose a 15.7 millimeter lens, set it for distance only, since clearly central vision was no better than probably 2400. I put the RX in. It was a free-form design, and the sagittal extremes of this particular lens, you can see, are better than a millimeter difference from the highest to lowest portions of the lens out at the edge. On the left, once again, a 15.7 millimeter diameter lens. I designed a center near multifocal with a 275 add and a 3 millimeter pupil. Put in the RX. It's a free form. And once again, here on the sagittal edge extremes, you can see that also we're just shy of about a millimeter difference between the deepest and shallowest portion of the edges of the lens. And a millimeter certainly is very significant when we're talking about scleral elevations. So very first pair of lenses I had on her eyes, that was a dispensing visit. We started with the glaucoma because we were concerned about that, and she said she was using the medications. I am not managing her glaucoma. She's at a glaucoma doc, but I measured the pressure and she's still at 26 on the right eye. The vision wasn't measurable on the right. The left one was at 20/40, so I was pretty good on the first lens. We hit that pretty nicely there, but you could see I actually over-minused her a bit, which is not really the best thing for a multifocal. So that was not really ideal, but I missed the script by a little bit there, probably due to the ocular surface disease throwing off the refraction enough. At the biomicroscope, the right one was well centered, but there was an excessive amount of inferior edge lift and it was pumping air in. It wasn't rotated at all, but this was a significant misalignment down at the bottom over there. The left one was actually looking quite good. 100 microns of clearance, a little shallow there. Phalangeal alignment was excellent, and it was rotated about 20 degrees counterclockwise. I did not dispense those because of what was going on with the right one, and since I had over-minused the left eye, I figured let's fix that up so she can actually have some vision. So on the right one, I increased the inferior peripheral sag. On the left one, I increased the apical clearance and the power change. So on the second pair of lenses, she's still 2400 and took some minus, but it didn't get her any better. On the left eye, though, now we're doing much better. 20/30 in the distance, and we have virtually no over refraction left there, and she was 20/25 minus at near. So that was actually excellent, very good. So just really a power problem on that first lens that I had designed for her. Right one was well centered. Now I had some clearance centrally. The phalangeal alignment was excellent, and there was no rotation. The left one was well centered, 150 microns of clearance, and the phalangeal alignment was 360 degrees all the way around very nicely with 20 degrees of counterclockwise rotation. I dispensed them. The right one, no changes, basically for ocular surface disease protection, comfort, and to give her a sense of peripheral awareness on the right side of her body. That really was the only purpose of that particular lens. On the left one, no changes at all. The vision was excellent at distance and near, and was quite a bit better than she was able to get in the glasses, because we were only at about 20/50-ish or so. Now we had her down at 20/30 in the distance, and even 20/25 minus at near. She was comfortable, and the physiology was excellent with those lenses. So let's go on to case number 3. 52-year-old white female, post-LASIK. And she self-referred in April of this year, purely out of frustration, which you will see where that came from. She had LASIK in 2006, one procedure on each eye. 2016 and on, she had gone through multiple visits with the surgeon, no treatment available to improve vision. So basically just turned her away with no answer to solve her vision complaints. So in 2019, she found out about scleral lenses, so she went to a scleral lens expert, worked with the scleral lens expert for 9 months, and failed miserably due to discomfort and not being able to see. So poor vision, poor comfort, and that was someone experienced at fitting scleral lenses, which, by the way, I know these particular doctors, and they are very good at what they do. So this is not just someone who's dabbling in scleral lenses. They actually do know what they're doing, and we're not unable to get this person successful. Second scleral lens expert was in 2021. That doctor worked for 7 months, failed due to discomfort, poor vision, and even had a bad experience with the doctor. So probably a personality conflict or something like that, but that did not go very well. And so she once again gave up on the scleral lenses. She saw a third physician at the end of 2021, didn't even bother with scleral lenses, put her into soft torics, and she failed with the vision there. She said it was constantly sliding. She was able to see and then couldn't see. It was just very, very bad. So she came in to see me, and she was wearing glasses. However, although they were RX for full time, she only wore them to help her at the computer and for reading. She does a fair amount of computer work. You can see the powers there. There's very little for distance in the left eye, which is why she probably walks around uncorrected. But the plus that's in the right eye was helping her out considerably. And on top of that, she had a PAL in there for 175. So that's a considerable amount of plus to help her for the computer and the reading. Vision uncorrected, because that's how she's walking around, was 20/50 minus and 20/30 plus. I refracted her with a little bit of cylinder in both eyes, but quite a bit of plus in the right eye. And she was correctable to 20/20 in the left eye. The ed was 175. And I noticed on the right eye, she has a corneal nodule at the superior nasal flap junction. Health-wise was good. She was only on progesterone and estrogen and no allergies to anything. And everything else was non-contributory. So I plan to do a distance scleral lens on each eye with the thought, because she does so much close work, if we can get a multifocal in there, I'm going to do that as well. But first, we just, since she had such a bad experience before, I said, let's just do a distance lens and see where we can go from there. So here are her scans, both the curvature map on the top and the elevation of the front on the bottom. And we can see right where that corneal nodule is there that we have a significant amount of elevation, about 90 microns. Here's the actual Scheimpflug image, and again, you can see the corneal nodule in that upper image lifting quite high. And then down at the bottom, I just tried to grab that and I rotated that image around so you can see that shadow that's dead center of that circle. That is actually the nodule that's coming up off the cornea over there at that junction. So it is pretty high, and that more than likely was in part for why she had failed with the previous scleral attempts. So here you can see the aberrometry. This time I happen to have this screen on the aberrometry, and you can see that we captured the aberrometry here on her. And this is the aberrometry summary, and we can see vertical trefoil measured at the minus 0.612 microns. We can also see that there's vertical coma of plus 0.548 microns, and a considerable amount of horizontal coma at negative 0.962. Just so you understand what those are for people who are not familiar with aberration data, normal trefoil and coma are generally between about 0 and 0.5, and you can see the total from coma she's dealing with is 1.12 microns. So that's a significant amount of aberrations that she's trying to see through, hence she's unhappy with her vision in her glasses. Spherical aberration is certainly a very common problem for post-surgical patients and post-refractive surgical patients. And here, the normal values for that are generally between about minus 0.40 and plus 0.45. And you can see she really doesn't have much spherical aberration. So her major problem is really the coma and the trefoil that's giving her the poor quality of vision, not spherical aberration. So here on the CSP Pro software, we can see during the scan that's being taken, you get feedback immediately about the QS, which is the quality of the scan. And in the upper left there, you can see it's checked with a green mark as acceptable quality. We can see in the second panel how much coverage we got at 15 millimeters. And here, in this case, it's 84% coverage at 15 millimeters. Again, the Scheimpflug images at 90 degrees apart. And there's that ribbon controller, so you can actually take a look at them all. And lastly, the coral scleral elevation. Now, I do my own scans, but for those of you who delegate this out to techs, this is a place where, while they're taking this scan, you can take a look at this particular data that is being given during the actual scan and give the techs sort of benchmarks as to what you expect so that you know that you're going to get good scans from them. Once again, we look at the CSP page, and we can see in this case, I took a two-shot capture. And the reason for that is, for the most part, I've really gone to taking 2 shots to capture. If they happen to be able to open their eyes wide up enough, I will get it on 1. But basically, the first capture, I'll do center and lift the upper lid out of the way, which is why that golden yellow section is going up so high. And then the second capture is that where I'll just pull the lower lid down and get that arc of the turquoise there. So that was 2-shot capture. 15.7mm cord. We can see once again that there's elevated nasal flatness and elevation, both on the arcs as well as on the graphical representation there. You can see that plus 150 magenta, deep magenta color is the entire periphery out there. The superior, inferior, and temporal, slight but mostly equal depression. They're really very, very close to 0. So there's not really a lot of depression out there. So it really, on this particular right eye, is all about the nasal elevation and that nodule that we saw there. On the left eye, again, I took a 2-shot capture. 15.7mm cord. Once again, the nasal flatness and elevation, very similar to what we saw on the other eye. And this one, we have superior and inferior depression is fairly increased. So again, no good reason as to why there's asymmetry between her eyes, but in this particular eye, we have a significant amount of depression on the superior and inferior quadrants there. The temporal is fairly even, kind of like the other eye was. So here are the 2 lenses that I designed. It's an 11.7 cornea, 15.7mm lens. I designed distance only. Put the RX in. It's a freeform total. The total lens was freeform, and the extremes on this sagittal edge was once again a little better than 1 millimeter to deal with the asymmetry out in the periphery there. You'll notice that the graphic on the back curvature there in the center is not that solid green anymore, but it's sort of green on one half and dark green on the other. There's a little blip down in the inferior portion, and that's because this lens really is a totally freeform design lens, and that darker blip centrally really has to do with where that nodule was, because that's how I was addressing that better to get this lens to negotiate over that nodule. On the left eye, similar dimensions, freeform total, and once again, you can see centrally we're not quite spherical over the central portion, but there's a little bit of asymmetry, although nothing like what I was dealing with on the right eye. The sagittal depths on this one is a little less than 1 millimeter of difference between the highest and lowest portions of the edge of the lens. So first lens is on the eye. Missed the right eye by quite a bit there, very hyperopic, but she did correct to 20/20, and the left eye hit dead on, 20/20 minus and a touch of cylinder. She got to 20/15 minus, so that looked very, very good. As far as the fit goes, 150 microns of clearance on both. The flange alignment was very good, but there was a slight toe up on the temporal edge of both of them. There was no rotation on either one. And so I decided not to dispense the lenses, given that that was so hyperopic on the right eye. I ordered a new one with the power change, adjusted the temporal edge to bring the toe down. And on the left one, since the fit was so good and we were really pretty much dead on, I ordered it with a little adjustment to that temporal edge to bring the toe down, but I added the multifocal into that one as well. Went ahead and brought it back for the dispensing visit for that second pair of lenses, and now you can see the right one was dead on target at 20/15 minus, just took a minus a quarter over that. The left one was very nice as well, 20/20 minus with a little bit of cylinder, and at near she was 20/20, so she was delighted with that. Well centered on both, 150 microns of clearance on both. The flange alignment was very, very good, and there's no rotation on either lens. I dispensed the lenses, brought it back for follow-up. Distance vision and comfort, excellent. She's wearing them full day. Near vision is fairly good, but she feels a little bit strained, and she's doing pretty well getting them on and off. Vision on the right eye is maintained very nicely at 20/15 with the minus quarter over refraction. Left eye, again, she's doing very, very nicely with that. Just a touch of cylinder there, and the near is still doing very, very well. Assessment at the microscope, the lenses are both well centered, 150 microns of clearance. The flange alignment is very good, and there's no rotation, so nothing had changed from the time I dispensed them. Basically, all I did was order a new one for the right eye with a multifocal, since that would help her out with the near, and I felt that would take care of her strain. And left one, we were done. No changes at all. I did see her back and she's doing very well with that multifocal on the right eye. So really, in just the course of a couple of lenses, we got her successful, despite the fact that she had had multiple failures over lengthy periods of time with scleral lens attempts in the past. Now here on this is a summary of the 4 models that are currently available. In the lower left, in the left-hand column, you can see basic, the HR, the AXL, and the AXL wave. And then across the top, I've put on the CSP software, the CSP Pro software, the axial length measurement and aberrometry, and which models can do which things. I'll just leave that up there for a second for you to take a look at that. And then I'm just going to move on. Okay. So in summary, Pentacam provides excellent source topography to design software-driven lenses for corneal, scleral, ortho-K, in this case utilizing the Wave software. The central scan provides greater chord captures than is possible with Placido disc-based topographers, because we can easily get out the CSP Pro software, and even not doing a CSP Pro capture, but on the AXL Wave platform, you can get out to 15 millimeters pretty easily. The CSP software requires 5 captures per eye while the patient fixates a central target. And that data can be captured to a chord of 18 millimeters, but more consistently, I found the captures of full data to be somewhere between 16.5 millimeters and 17 millimeters. On the other hand, the CSP Pro software typically captures the eye to a chord of 18 millimeters, and in the patient can retract the lids enough, this can be done in a single capture. The single capture is about 2 seconds worth of time, so it's very nice. But I do find that most commonly I'll take 2 scans, where on the first one I'll just lift the upper portion of the lid, and then get the central and the upper scan, and then on the second scan I'll just pull the lower lid down to get the bottom portion of the sclera. Due to the camera system that's in the AXL Wave, the non-CSP Pro central capture is typically 90% of full coverage or greater at 15 millimeters. So even just taking that central capture without even using the CSP Pro software, you're getting an enormous amount of data out to 15 millimeters. The Pentacam directly measures true corneal elevation data. It's not algorithm derived from tear film reflected curvature data, such as in Placido disc or even some of the other scleral elevation measurement devices. Tear film quality is not an issue for the data collection. It doesn't play any role whatsoever. And in addition to the topography and tomography, scleral profilometry, the Pentacam provides many other corneal metrics such as pachymetry, densitometry, light reflectivity, and transmissibility. This, along with that sophisticated analysis displays, really gives you excellent information for diagnosis and management of various corneal conditions, things like keratoconus or following cross-linking management, etc. The AXL Wave adds to the above with axial length measurement and full eye aberrometry, further enhancing management of myopia progression, corneal ectasias, IOLs, and ortho-K treatment, etc. And with that, we're going to wrap up tonight. Thank you very much for coming out, and I hope this has been very informative for you.
Thank you, Dr. Mahler. That was really great. And to everyone watching, if you have any questions, please type them in now to the GoToWebinar screen. We do have a few questions ready from the audience. The first one is, how do you use the aberrometry data clinically during a scleral lens fitting?
Right now, I think aberrometry collection data is more for an academic clinical use, as opposed to really being able to apply it clinically, although that absolutely is sort of burgeoning technology. Because clearly I can see that having aberrometry data, number one, without a lens, you can answer the questions easily as to why a patient may be complaining at 20/20 acuity or even 20/15 acuity, and they're still not happy, and you can see where the aberrations are really detracting from the quality of the vision. And then, although I haven't really done it much, I've done a little bit with it. Once I'll get a lens on there, I'll take the aberrometry scan once again with the lens eye combination to see how that's been reduced. The next step, logically, will then be able to take that measurement and add that in to the actual lens design have that lens incorporate those optics and go ahead and improve the quality of the vision even further. And that absolutely is going to be in the very, very near future.
Okay, great. Thanks for that. We have time for one more question. Has the Pentacam CSP Pro decreased the number of office visits and chair time for your scleral lens patients? If so, how much?
It absolutely decreases the chair time and numbers of visits. If you take a look, even look at that last case, we saw two very experienced scleral lens fitters work over 9 months and 7 months respectively over there. And in the course of, what was it, 3 visits, I had her in a multifocal doing great for the entire day. So it absolutely decreases the amount of remakes. Remember, I did not in any of these 3 cases use any diagnostic lenses. Basically, the very first lens that I put on was my diagnostic lens. And as you saw on that, for the most part, I had the fit nailed down on that first lens. So that first lens is really an excellent launching point if you want to then go ahead and just tweak anything about the fit, as well as fine tune in the optics so that they can see the best. And really on all 3 of these cases, you can see that's exactly how they all proceeded. So yes, it really does cut down both chair time, numbers of visits, numbers of lenses needed, as well as also attaining a better product at the end point. Because again, even on that last case, despite all the work and all the various lenses that were done, she failed in every one of those lenses. And so the final designs were not sufficient to meet her needs, whereas I was able to get to that actually fairly quickly.
Okay, great. Well, thank you for that. That's all the time we have tonight. Thank you again to everyone who attended, and thank you, Dr. Mahler. Before we finish up tonight, did you have any final thoughts?
Well, thank you very much, Adrian, for running a fantastic show here tonight. I really do appreciate it. It was all seamless. Thank you for all the attendees that came out tonight. I hope this really did answer a lot of the questions, as well as make it clear the various platforms of Pentacam as to what they can each achieve for you. And my final thought is that the AXL wave that replaced my my basic Pentacam about 1.5 years ago, and it is an absolutely phenomenal instrument, and it's only getting better. So I really have found this to be an enormous leap forward over the Pentacam Basic. And not that the Pentacam Basic is a poor machine by any stretch of the imagination. It's very good, and it really does allow good captures as well as good information about corneas and even good lens designs. But the AXL Wave really streamlines that process by making the captures easier. It's easier on the patient, it's easier on the doctor or the tech who's taking the pictures, as well as you can even get more data that way and in a much faster fashion. So it really is an enormous leap forward, both in hardware and software. So that would be my final thoughts on everything we presented tonight.
Okay, great. Thank you again on behalf of Oculus. Everyone have a great night.
You as well. Bye-bye.